Hello, everyone, and welcome to Cancer Speak, the official podcast of Cancer, a journal of the American Cancer Society. I'm Dr. Priya Kumthekar, a neuro-oncologist at Northwestern University and the Neuro-Oncology Section Editor for Cancer.
And I'm Dr. Helen Shih, a radiation oncologist at Massachusetts General Hospital and Mass General Brigham, and the Radiation Oncology Section Editor for Cancer. Thank you for joining us. Dr. Kumthekar and I are excited to be speaking to you all today. It's not often that a neuro-oncologist and a radiation oncologist get to sit down and talk in depth about this topic.
Yes, absolutely. And today's discussion is especially timely following this year's Society of Neuro-Oncology, or SNO, annual meeting. We're grateful to Cancer Speak for having us, and we're looking forward to diving into an important and involving area, lower-grade gliomas and IDH inhibitors.
We'll be talking broadly about which patients and at which point in their treatment course may be best suited for IDH inhibition, especially in the context of the INDIGO trial and the FDA approval of IDH inhibitor vorasidenib.
Yeah, and that's probably the best place to start, I would say, is a quick refresher on the INDIGO study, which I'm sure most of you are quite familiar with. But this was, of course, a multi-center, multi-international study of over 300 patients with grade 2 gliomas, IDH mutated, who were randomized 1-to-1 to either vorasidenib oral daily or a matched placebo oral daily. And here the primary endpoint was progression-free survival, but there was also this key secondary endpoint of time to neurologic intervention and other secondary endpoints that were captured, for example, seizure control, quality of life, etc. So what we ended up seeing with this study design, one is that we saw accrual happen faster than expected. So we really saw kind of a need for this patient population. And then in terms of primary outcome, we saw that the study met its primary outcome with an improved progression-free survival, or PFS, going from 11-ish months to 27-ish months. So an almost 2.5-fold increase in progression-free survival. And in terms of that key secondary endpoint, which some might argue in some ways is more important because, like, when are you intervening actually for these patients, that time to neurologic intervention actually wasn't even met for the treatment arm, for the voranigo arm, and was at about 1.5 or 17.8 months for the placebo arm. So really see this nice extension of progression-free survival and extension of time to neurologic intervention, which of course led to its FDA approval shortly thereafter.
And then, of course, that becomes the question, is this suddenly, I think the confusion became, if you looked at just this study alone, wow, is this the answer? You know, we have a new class of therapy, targeted therapy that actually works in lower grade gliomas. And if we extrapolate from targeted therapies that we see in other tumors like melanoma and non-small cell lung cancer, where sometimes he's taken the lead to traditional chemotherapies or radiation treatment as the standard of care, and there was a lot of enthusiasm and interest in thinking about that. But of course, then when you say, wait, let's put it in context. What were we doing before this exciting turn came about? And it's like, oh, wait, we actually have a standard of care, arguably a combination of radiation and chemotherapy, defined, for example, by the RTOG 9802. But of course, both radiation and chemotherapy have significant toxicities. And I think that's where a lot of the enthusiasm of finding new ways of helping this patient, of largely younger adults who are very motivated to accept new therapies with their risks.
Yeah, I love how you said that, Helen, because what really struck me is when you started out with, is this the answer, right? And I do think that was the question going through so many people's minds. And the way that I see that question, just with like a slight reframe, is not, is this the answer, but is this an answer, right? Is this one of our tools? Is this one of our chess pieces on our chessboard of this longitudinal, hopefully as chronic as possible disease? And I think that's sort of the lens by which to view it, because, you know, we see here an improvement in progression-free survival, but we're still not talking the C word. We're still not saying cure with this drug, right? It's not the answer. And I think the way that I counsel my patients is more along the lines of, this is fantastic news, right? We're so excited. We're all, I think, uniformly excited in the field about this drug, but this drug is one of the pieces on our chessboard. It's one of our weapons that we have, and more is better in terms of what we have in our arsenal. But it doesn't mean in this chronicity of their disease that they're not going to have chemo or that they're not going to have radiation, that those are at this point inevitably going to happen, but it's just the timing and placement of that might be impacted by this drug.
Yeah, exactly. There's so many unknowns in that course of knowing the timing of like when would use this new opportunity that clearly has activity for these patients. And in the patients themselves, IDH mutant gliomas is a wide spectrum. We know that there's those that are just IDH mutant astrocytomas. There's the coded-leaded oligodendroglial type feature tumors that have a much slower, longer time course. Do we treat them all the same? Is it different? And the timing. And I think one of the great things about the INDIGO trial, one of the many great things about the INDIGO trial is that it really capitalized on the fact that there were a lot of these patients that were out there who had chosen not to follow what we would otherwise consider standard of care postoperative chemoradiation. They understood that was what was being recommended by at least some people because, for example, they had residual disease, but just felt personally that was not right for them or not the risk they were willing to take, even though they knew there was a survival benefit, but also came with a risk. And I think that's where the INDIGO trial, I think, fit nicely in. But I would also temporize it and say it was randomized to placebo so that it could show prospectively there's a real signal, but also caution my patients to like realize that was not compared to standard of care. And this is what adds to the uncertainty and confusion. We know it has a real role. We're not really sure how and when to put it. But if you only had one treatment to give ever, then we would probably want to throw all three maybe at them. I don't know, right? Like, I don't think we would not want to have chemotherapy and radiation as part of the armamentarium as well.
Yeah, no, and I think that really brings us to the crux of today's conversation, which is where does this fit in the real world? So in your practice, for example, Helen, where do you all typically fit in vorasidenib?
Yeah, I think it varies a little bit based on who the team is in terms of the neuro-oncologist, the radiation oncologist, and the patient. They're all parts of the pie. My personal bias is based on the location. I'm thinking as a radiation oncologist, a little bit more like a surgeon, where it's like local. It's like the size, the location of the tumor. So if I know I'm going to treat with radiation, the tumor is particularly large and diffuse and it's getting a little bit closer to like half the brain getting irradiated, gosh, I just feel like the risk of side effects of radiation are going to be that much greater. Then those are the patients that I'm a little bit more prone to saying, you know what, go ahead, let's try something else to put off radiation. Or the tumor is right up against, for example, mesial temporal lobe near the sella. I feel like there's going to be a high risk of causing pituitary dysfunction from the radiation, which we see in a year, 2, 3 after radiation exposure with even low doses. And it's certainly in a lifetime of these patients. I think those folks, at least I feel like have an added benefit to avoiding radiation early.
Yeah, it is really that risk-benefit ratio, and I can see that in the situation you described. I also think on the opposite end of the spectrum, and this goes back to that risk-benefit ratio, those with gross totally resected tumors or near totally. On the INDIGO study, they did have measurable disease. They were allowed to be post-operative, but had to have measurable disease. But here, because of the slow-growing nature, oftentimes we can watch them really closely, and then if we do see a change, dive in, right? Because we don't want that volume to be large. To your point, large volume with radiation, likely more neurotoxicities. We don't see these tumors typically explode. So if we can watch them and keep that volume small with vorasidenib, which by the way, the post hoc data did show that there was volumetric trends downwards, even if we didn't get true partial responses.
It is the extremes, and it's extremes for two ends of the reason. I agree with you. I know that it's certainly those were not the patient population in the INDIGO trial, but that is exactly how I extrapolate also. Like we know there's microscopic disease there. That's why it comes back at some point. And it made sense in the INDIGO trial that you needed something measurable because otherwise in a very slow progressing disease, how do you know you have any response? We don't have better molecular imaging or other biomarkers yet. I really love that idea also of getting in even before there is a substantial target to contend with.
Right. And in some of, again, this post hoc data, we've seen with the INDIGO study that because it has this potential to very gradually bring down volume, which we didn't really capture in the original publication because we count partial response as a 25% reduction. So we didn't quite get there. But where I think that that's really interesting is it can be disease modifying. So early intervention for some patients in particular can be disease modifying. We can think of it as a disease modifying agent almost similarly to what we have in, say, multiple sclerosis or other diseases where you need that early modification. So, there's still so many challenges and unanswered questions, I think, on placement of this. I think the other piece is we already have patients who have had, let's say, radiation and chemo 3, 5, 6, 7, 10 years ago. And they're coming in with progression, and we're using vorasidenib on a lot of those patients. And understand we're doing that, not, of course, mimicking the INDIGO study. And so here we're a little bit in uncharted territory, but it seems to anecdotally being used in that setting, at least I certainly am.
Yeah. And I feel like that's exactly what we do across the board anyway. You have a patient, they have a recurrent disease, we've already gone through this standard of care armamentarium. We do exactly that. We're like, well, what are the other systemic agents? Is there an opportunity to re-irradiate, even though that's not standard, or do a second surgery? And I think that makes a lot of sense, actually, even though it is not as yet supported or defined or confirmed by a prospective randomized trial.
And I'll have to say, this is not the first time that I've seen a new drug come out, right? Because I also treat, and so do you, metastatic disease, other disease states. And I've noticed in myself, my approach to using vorasidenib is even different than some of those other drugs because it's so well tolerated. My knee jerk and my threshold to trigger and start it has been different, quite frankly, if we're being honest, because in quality of life, and you go back to that risk benefit ratio, and we have seen, again, post hoc data and anecdotally in my patients, I've seen seizure frequency go down, potentially because of this 2-HG kind of reducing that glutaminergic output. We're not having a detriment to quality of life, and we might even be having an improvement in some of those select cases. I have found that if I'm borderline, I lean towards, all right, let's go ahead and start it because, it's not going to impact you day to day.
And we keep also the patients engaged in these conversations and like, this is what we know, this is what we don't know, and this is what we're thinking. And I think pretty much virtually every single time they also will say, I get there's just uncertainty or there's just uncharted territory. I'm willing to take the risk. And at the back of my mind, I'm always a little bit cautious and still not cautious enough that we don't take the risk because it makes sense. The benefit seems to outweigh the risk, but it will be great to get confirmation that we aren't somehow changing the biology of the tumor, making it less radiation sensitive when we actually need the radiation, or less chemosensitive one day when we need the chemotherapy. But we have to help the patient that's in front of us today. And they are usually oftentimes working adults. They've got kids, they've got their own adult parents are taken care of, and feeling their best and doing their best is very much, I think, the priority for many patients.
Yeah, you actually took the words right out of my mouth for that last part, because I was going to add that I loved that they were the other piece of your pie, because it's so true. And that pie piece, if we're calling a spade, looks different than our glioblastoma pie pieces often, because they're kind of in that sandwich generation of taking care, because they're a younger patient, they're taking care of their kids, they're taking care of their parents, they're in their highest earning potential years. I mean, they're in that thick life is lifing moment and a huge part of the conversation. But definitely unanswered questions and challenges from the ones you've mentioned to monotherapy, combination therapy, timing, duration. So I definitely think there are a lot more studies to be had.
For sure. I think the field just went from exciting to just outrageously exciting, with so many opportunities, both for us as a clinician frontline in terms of best estimating how best to integrate what we know with what we don't know. But it is just a playground for the investigators out there, whether it's basic science, preclinical, or clinical research, to really take on this challenge of defining the next best step in cancer care for these patients.
And I do think we saw tidbits of that at Society of Neuro-Onc, or the SNO meeting this year too, in terms of IDH exploration more, whether it's, I saw some ongoing studies with newer or different IDH inhibitors. So they're continuing to iterate on the science that we have so far to continue to improve what pharmaceuticals we might have available for us for this population. And also, to your point, more on the understanding of, is it a radiation sensitizer? Or does it somehow make you more akin to respond to radiation? Or lots of post hoc analyses.
I think that pretty much summarized the excitement of clinical practice for lower grade glioma IDH mutant patients today. And I agree with you that we're going to have a lot more to talk about in years to come.
As we wrap up today's conversation, we want to take a moment to speak directly to you, our listeners, as some of the newest section editors for cancer. We are always looking for high quality research submissions that advance the care and outcomes for our patients. And we'd love to invite you all, our colleagues working in neuro-oncology and radiation oncology, oncology and any other neuro-oncologic spaces, radiation oncology spaces, to submit your work to cancer?
Yes, absolutely. Cancer has a global reach, which is great and different to when we think oftentimes in our specialty field. It's great to talk amongst ourselves in neuro-oncology, but what better to really have a global reach to really educate the rest of our colleagues within the cancer space, to be affiliated with the American Cancer Society. And I think as this field is changing, whether it is on the systemic therapy fronts, new technologies and radiation integrations, new surgical approaches, imaging, understanding the molecular features, this level of novelty is appreciated by our other oncologic colleagues. And you get that wide breadth of readership in cancer, particularly for those clinicians that are seeing everything and doing everything and not so specialized as many of us in academia. I think it's a wonderful place to hopefully land your work, and know that the submission process is easy. The editorial team could not be more supportive. There is a robust social media presence, and this will hopefully both promote your careers as well as the care of our patients.
Absolutely. I couldn't agree more. And that brings us to the end of today's episode. Thank you all for joining us for this conversation.
We hope you found it helpful. We look forward to future discussions here on Cancer Speak.